So how do I do it? What has made a difference in my treatment of patients and outcomes of patients with TLIF? It is precisely what has been talked by Dr. Iyer and others before him, I think Vishal, about the ERAS procedure. So years ago when I read about this, we started spine care pathways. Once a surgical decision is made, initial screening for comorbidities and habits has been done. We divide patients into low risk, medium risk and high risk, and a low risk population directly goes into fast track for surgery. This is then, they go through what is called as the ERAS protocol. And what do we, the people whom we select for ERAS protocols are low and medium risk patients, typically 1 or 2 level lumbar spine fusions, age less than 75, ASA grade less than 2 and BMI less than 33, and to edit those who do not have a neurologic deficit. What does ERAS protocol in my setup comprise of? It comprises of pre-operative patient optimization, a decrease in the perioperative stress, maintenance of the post-operative physiologic function, and accelerating the recovery time. So pre-admission, you spend a lot of time on educating the patient and optimizing the patient's medical conditions. You counsel the patient, give them all the surgical information that is necessary, nutritional assessment. These are all degenerative spondylolisthesis are all, most of them are elective patients, so you should build up bone strength, stop smoking, limit alcohol consumption, or stop blood thinners whenever possible. All those things should be done. The second thing is pre-operatively, the patient in our setup gets admitted a day before and is assessed by the anesthetist. We take care of breathing and lower limb exercises. Protocols are taught for the post-operative mobilization, and fasting is limited to 6 hours prior to the surgery, but we do continue giving clear fluids right up to 2 hours before the surgery. In the surgery, we do measures to limit the perioperative morbidity. Unlike the big old whacking incisions which we used to do in the good old days for doing a posterolateral fusion, today for a single level posterolateral fusion, the incision is only this much. A single level TLIF, the incision is only this much. We do not dissect beyond the facet joint. We do not dissect the muscles in a single level transforaminal lumbar interbody fusion. We try to see that we do an over the top decompression so we don't dissect the muscle on the opposite side. So there are a lot of effort which is being made with routine posterolateral fusions, with routine open transforaminal lumbar interbody fusions to make sure that the patient's, the amount of surgical morbidity is reduced. Along with that, I have not put an indwelling catheter in years for these kind of patients for single or 2 level fusions. Antibiotic prophylaxis is given, antiemetic prophylaxis is given. We give tranexamic acid to reduce intraoperative blood loss. We make sure that fluids are restricted during the surgery and even after, so that the patient does not have to hurry to pass urine. The patient is asked to evacuate the bladder and come to the OT. As I said, limit your surgical morbidity, meticulous hemostasis, local bone is used for fusion when necessary. Do not take an extra incision. Periradicular infiltration, use multimodal analgesia, use periradicular infiltration around the nerve root. Use skin and muscle infiltration. I think a lot of joint replacement surgeons, you all use what is called commonly the Ranawat cocktail after your surgery in order to help post-operative pain control. So we do all that in spine surgery too when you do an open surgery. And it is this type of a protocol which has made a huge difference rather than the type of surgery. So I think whether you do a MIS TLIF or an open TLIF, or whether you do an open TLIF or do a small posterolateral fusion, the outcome is exactly the same as long as you follow all the other things that you are supposed to do in taking care of the patient. Postoperatively, we limit fluids, we give adequate analgesia, we start orals early in the postoperative period. Patient is seen by the physiotherapist within 4 hours of surgery, mobilized out of bed within 4 to 6 hours, encouraged to go to the washroom to pass urine. We make sure the biggest problem in the Indian scenario is the bowel. If they have not opened bowel, they are unhappy, so we take care to appropriately treat them for that. And we encourage early return to function. Discharge is when adequate pain control is given with oral medications. They have an ability to climb stairs. A bowel movement has happened. No intraop or perioperative complications. Since we take subcuticular sutures, self-removal of the dressing is done at home. Progressive increase in activities of daily living within limits of pain is advised. Our phone number of one of the fellows is shared with the patient so that they can make a call. A call is made to them 2 days and 1 week after discharge to check status of recovery and allay concerns. 108 patients, ASA type 1 and 2, no significant neurologic deficit preoperatively. Primary surgery was a lumbar fusion. Mean age was about 70 in these patients. You can see the blood loss and the operative time was minimal. Post-operative Foley's catheterization was required in 4 patients. Nausea and vomiting, 3 patients complained of severe nausea, vomiting. But most patients' exercise was started within 4 hours and patients were mobilized out of the bed the same evening. To conclusion, again what Ayush said, modern healthcare, all these years healthcare was SF1. The surgeon decided what was good or bad based on the technical result or how well his X-ray looked. Today, outcomes are decided by SF36. It is what the patient wants. So modern healthcare is about delivering what the patient expects and wants. The ERAS program has reduced perioperative complications. It allows faster mobilization, shorter hospital stays, earlier return to activities of daily living, and improved patient satisfaction scores, irrespective of what type of surgery. We do all. In my practice, I do an open TLIF, a minimally invasive TLIF, a posterolateral fusion. All my patients do equally well. Thank you.